Yeah, my name is Michele. I'm a digestive surgeon. My main affiliation is the IRCAD in Strasbourg, is the Research Institute Against Cancer of the Digestive System. And the second affiliation is the University Hospital of Strasbourg. Mostly in the clinical field for perfusion assessment and for fluorescence cholangiography. Then we have a bunch of research ongoing in many applications, including lymph node mapping, and of course cancer detection, playing with new probes, and ureter visualization also with new probes, and also with some, let's say, custom-made probes. We work together with chemists. We have created a research unit totally dedicated to the advancement of fluorescence imaging, including people that do hardware, chemists, and also software engineer, with the aim to provide a quantitative assessment of the fluorescent signal. Well, for perfusion assessment, clearly we have provided quite consistent data that it enables to identify more clearly the optimal resection site to perform the anastomosis in a healthy tissue. For fluorescence cholangiography also, we did one of the first trials that was published in the Annals of Surgery, in which we could demonstrate that it enables a good visualization of the relevant structures with an economy in terms of time when compared to the standard X-ray based cholangiography. Well, for gallbladder, increasingly, for my patients, yes, but in the institution, not everybody uses it, also because cholecystectomy is a teaching procedure that's often performed by residents, and that we are struggling a bit to make the majority of surgeons adopting it. So some of our colleagues do not really see for now the interest, but this is not my opinion. So I think that everybody should routinely use it for any single cholecystectomy, even for the easy ones, even if everything is clearly visible, but still is also to, let's say, change the mindset thing. And so from this shift in the mindset, you can expect that one day you will have the case in which you really will see, wow, hopefully I used it. So, but it is by implementing it in a routine fashion that it would become really spread and widely adopted. Definitely, I believe that it will become a standard of care, and that not doing it will be below the standard of care. Well, I joined the society in the day one, practically speaking. I was attending the very first meeting, and the advantages, of course, a great networking with the best persons in the field, so a great sharing of projects, ideas, and that's something that really can promote the field to move really to the next step. What's the next step? Yes, there are many windows of opportunities in this field. I really think that the four elements that you need to master to really make this field relevant is the fluorophores, the hardware, the software analysis of the signal, and of course preclinical and clinical applications. And those four things have to progress simultaneously. So fluorophores, the need of more smarter, let's say, fluorophores that can selectively highlight the cancer tissue, for example, or even simply separate the healthy versus the unhealthy tissue. It can also be in terms of perfusion evaluation. The second point is, of course, the sensitivity, working on the sensitivity of the hardware, or producing more ergonomic hardware flexible endoscopic near-infrared enabled platforms, or even Google that can capture and transfer to the eyes of the surgeon the augmented signal. The third, as I was saying, is the software analysis, because what we are visualizing so far is simply a qualitative enhancement, which requires a computation, a calculation to provide something that is measurable and that is that you can standardize, that you can compare intergroup and intra-individual as well. And of course, fluorescence imaging can make possible things that are not without. So you can even figure out new techniques that are made possible thanks to the fluorescence imaging. You can go really for the example that I make often is the possibility to do early stage cancer removal by pure endoscopic technique. The example that I make often is the ESD, so the endoscopic submucosal dissection. Thanks to fluorescence imaging with antibodies, with monoclonal antibodies that target specific cancer transcript, can possibly enable to be sure that you have removed, that you have done a full oncologic procedure with the removal of the whole old cancer tissue. So you can basically close the loop. You can be theranostic somehow, so you can diagnose and then be sure that with your procedure you have removed the integrality, the totality of the cancer tissue. So, and this is of course mandatory if you want to decrease the recurrence rate of tumor, of cancer.